السلام عليكم ورحمة الله تعالى وبركاته. بسم الله الحمد لله والصلاة والسلام على رسول الله سيدنا محمد وعلى آله وصحبه أجمعين. Welcome once again, ladies and gentlemen, to Sudan Health Professional Education Conference 2023. We'll start today our first presentation with Dr. Omar Osman. Dr. Omar Osman is a personal friend and colleague and emergency medicine consultant. He received his fellowship in disaster and emergency medical services from Brown University, Rhode Island, USA. Currently, Dr. Omar is a health cluster, the first health cluster head of disaster management unit and administration in King Saud Medical City in Riyadh, and he's been involved in many developmental projects at national and regional, and he has a lot of ongoing projects in this field in the context of improving the emergency medical services, disaster and emergency care in Kingdom Saudi Arabia. So as we navigate through the unprecedented times that started back in COVID-19, probably the wisdom and lessons that Dr. Omar Usman will share with us will not only hopefully impact our efforts to navigate such crises with the concept of education continuity in mind. So I'd like in this very particular moment to welcome Dr. Omar Usman to provide us with their experience in Saudi Arabia in the medical training during COVID-19. Dr. Usman, the floor is yours.
Thank you, Shan, for the kind introduction, and thank everybody for attending. I would like to thank the organizing and scientific committee for giving me this chance to talk about one of the topic that I feel like it was ignored before and nobody maybe talked about it enough. And I think if we want to talk about the session or what we learned from COVID, it like we'll have so many years in front of us to talk about the session and the lesson that we learned from this specific topic, I mean the COVID-19. So I hope I can shed some light on how COVID-19 affected the training program or the emergency training program, and how we can learn or advance from that point forward. Next slide, please. So my content will have some introduction about the effect of COVID-19. Then I'll talk a little bit about Saudi Board of Emergency Medicine and where COVID really hit us hard. Then what the impact on training, and after COVID, how we develop the training around the situation. And then we'll talk what will happen after that. So we'll move on to the next slide. So for the introduction, so as you all know, no, keep the previous slide, please. So as you all know, COVID affected everything. And when we talk about training only, so if we take like this very small topic, very specific topic we're talking about is the training. So looking at how COVID can affect the training is very, very difficult. For the people who are not interested in training itself, they will find the difficulty obtaining where we change or what exactly change from the point when we started before COVID and the point after that. So talking about COVID effect on emergency department, which get affected very, very badly, and then looking at the resident and then looking at the training or resident training program. It's very specific topic. So I think getting the lesson learned from that topic is very important, and to reach to the point where we can learn from what happened before and develop our program for after, it's very important thing. Next, please. So again, emergency department was one of two major departments, let's say, affected by the COVID-19. So emergency and ICU, probably one of the highest departments that get hit hard by COVID-19. Other departments get injured too, but most, if you're working in those two departments, you will know when we talk about stress disorder, psychiatric disease, maybe death also. If we talk about death, you know that this area were the most affected by the COVID-19. Next, please. So I'm sure, like I saw a lot of names that are emergency physician, and if you are working in emergency physician like our department, or I'm sure your department probably busier. If your department is like this, and you add a new incident to the department, then you are setting a stage for a catastrophe. Your department cannot tolerate any more pressure than it is now. So when you get the pressure and the extra pressure of COVID-19 or any incident after that, then you expect to face this with difficulty and a catastrophe, and the disaster could emerge from that. Next. So if COVID-19 is a sad topic, everybody would ask why we're still discussing COVID-19 like 2 years after it's ended. So it doesn't affect anybody now, and probably the mortality rate is reaching or approaching the normal upper respiratory tract infection for now. But why we're still talking about COVID-19? The only reason we're talking about COVID-19 for now, it's to reach to the point that we get and we learn everything from what happened before to a better future. So I'll talk about this lesson maybe by the end of my slides, but for now, we're talking about this topic because we need to talk about this topic. We need to get everything we can from COVID-19. Next. Before we start, I'll give you some hints about the Saudi Board of Emergency Medicine. Probably some of you know that because you worked here or you saw or you trained probably in those training program. But I'll shed some light on the Saudi Board of Emergency Medicine. Currently, I'm the regional program director. Next slide, please. I'm the regional program director for Zone 1, which is Riyadh Zone. So there is 3 training zone for Saudi Board of Emergency Medicine. Zone 1, which is Riyadh only. And Zone 2, which is the Western Province, and it's covering from Tabuk down to Abha. And then Zone 3, which is Eastern Province. Why Zone Riyadh is alone? Because like 60% of our training program, emergency training program, is in Riyadh. So though the other zones are bigger in size, still we have more than 60% of the training resident here in Riyadh. We have like 300 training residents currently on board, and we have around more than 100, actually, it's not 100, it's more than 100 training residents per month who's coming from other services, GS, medicine, ICU, family medicine, gynae, a lot of training residents coming to us, taking their off rotation or their ER rotation in the training center. We have 10 training center accredited by the Saudi Commission in Riyadh, probably more coming on the way. I think they will become 12 by the end of this year. So 12 training program. Every training program has their own trainer, their policy. They are working with the Saudi Commission with the same policy. We have many students and intern. We have like monthly, we have more than 20 student or an intern per center. So the number is huge actually of student and intern within the Zone 1. I will not talk about the other zone, but whatever I mention on Riyadh Zone or Zone 1 will apply on the other zones. Next. So what happened in March 2020, where I know it's called COVID-19. Some people always ask why it came in 2020 if it's COVID-19. It's actually started in China in 2019, but it didn't came to us. Next slide, please. It didn't came to us in Saudi Arabia. It didn't hit us in Saudi Arabia until probably March, maybe end of February and the beginning of March, and why that happened? Because of the Saudi Arabian restriction on the traveling and on and the social destination that's happened early on. So the rate of infection started earlier, probably at January or the end of January, but the real increase or growing in number started later on, around March time, end of February time. Next, please. So one of the things that's happened due to the early restriction on traveling in Saudi Arabia, we got so many of our training program residents stuck in a different place in the nation and outside the nation. So I have like, and our training program is around like, I have 10 or 15 residents who are stuck in different places in the country. Some of Jeddah, some of them in Jeddah, some of them in Eastern Province, some of them in the north, some of them in the south. and like 4 or 5 were stuck outside the country, actually in a different places, unable to come to Saudi Arabia and help us in managing the disaster that was happening. Next, please. Also, Riyadh have one of the very interesting feature. It has like more than 7 or 8 largest hospital in the nation, and maybe in Middle East as a whole. Like we have around 400 ICU bed or 300 ICU bed that is functional, and we have more than 500 ED bed actually. And this is actually make us think that Riyadh is untouchable. Nobody, whatever the number of infection, we cannot reach to the degree of a disaster, whatever happened. And we thought we are untouchable to the degree that we start sending help to other city in the nation inside Saudi Arabia. We sent some nurses, some physicians outside Riyadh helping the other city and in the country to absorb the growing number of infection. Next. But May 19, May 20 came very fast, and May 20 it's around Ramadan time that year in Saudi Arabia. Next, please. So what happened? The number of ICU admission, which was started very slow, we were like around 120 patients at the same time admitted under ICU. That number grew very fast to reach 400, and we reached, I think, at the same time it reached around 520 or something like that. So the number of ICU bed at that time, the real ICU bed capacity in Riyadh was around 300. It could reach up to 400 probably if we stretch out, but the maximum we could reach actually with stretching out all the resources, I'm talking about Riyadh city alone. So when we stretch out all the resources, it was probably 350 or so. So we reached 500 or 480 patients at the same time admitted. So at that time, exactly, most of our facilities was surging, and they surge of around 50% or 40% over their capacity. Next. What added to the pressure that the quarantine, which we were quarantining people in hotel, and this quarantine area was covered by medical staff. So some of our staff were outside helping in hotel, checking on patient, doing PCRs. So we lost like part of our manpower, which was working in the hospital, into this hotel. And then we utilized the primary healthcare center to do that later on. But at the beginning, they were staff from hospital, or within the hospital, and they were expert staff actually. Next. So early on COVID, because the precaution was a little bit light, I would say, and our staff, nobody cared about precaution. I mean, until now, probably you'll see that some of the staff, they don't follow the precaution. I mean, the PPE, the mask. A lot of staff, they didn't think it's serious until we start seeing a number of staff get infected, and we actually lost some of our colleagues. We got some people or some of our colleagues admitted to ICU or went in a critical condition, and we lost some to this disease. So at the same time, I saw like 1,000 medical staff or medical personnel out of service because they were infected or they were COVID positive at the same time. Next. So if you heard this, I hope that you will understand what situation we were in. And now when we talk about the impact of COVID-19 on training program, you probably can guess some of what happened on the training program with this pressure that I mentioned before. Next, please. So as you know, and as probably mentioned by my previous colleague, they were talking about classroom activity. And this is like the only time where the residents sit with their trainer or their teachers and talk about pure knowledge. They don't discuss cases. They probably do, but I mean on the training level, this is one of the time. That's why we call it academic. It's the only academic time per week that the resident sit and learn in an environment there will be no pressure, no patient, nothing else is there. One of the things that get affected early, the academic activity, social destination, and the inability to move within the city, even within Riyadh city, they blocked our movement to the activity or within the activity. So the activity was held and stopped almost 1 month after the COVID-19 started. So and that resulted actually to the resident losing a lot of basic knowledge, time to learn or time to teach or time to get taught, and a lot of communication also were lost within that time, because as my colleague mentioned before, peer teaching or peer education, peer discussion is one of the important factors that support the education at this period, and it was lost because there was no enough lecture hall that can carry the huge number of residents without keeping the social destination that was applied by the country. Next. Also the ER. In ER, we lost a lot of staff because of the social destination policies. So our ER is mostly crowded, like most of probably yours. And when we getting like most of the intern or most of the student to a crowded place, the number of infection get higher. So what we did actually, we reduced the number of staff per shift, we reduced the number of residents per shift, and that's mean less exposure, less education, less discussion, and the resident have more patients, so less time for discussing cases with attendees or with senior staff within the shift. Next. What else happened actually, and it was surprising because at that time most of the people were afraid actually of the infection. Most of the university within Riyadh city, they canceled the intern and student rotation, so the student and the intern stopped coming to our ED, specifically ED and ICU. So they stopped coming there, and those are a good manpower were helping at least in documentation, following patient result, checking, ordering, and doing a lot of things within the shift. They stopped coming suddenly, and not those only. Actually, the off rotation of other services like GS, medicine, family, who were rotating with us every month, they stopped coming to ED. And with the reduction in the number of residents per shift, this resulted in a huge deficit in manpower every shift. And the number of cases were growing very fast. We were doing many intubation per shift, and the number of staff that can do or deal with those sick patients were much less. We're working half of our resident capacity or trainee capacity. Next. Some of my residents, and probably they don't share that a lot, so a lot of people, they don't know that some of my residents were having comorbid disease. So I have like one resident with MS, I have so many with diabetes, and I have a lot of obese residents. Those residents are at high risk of developing more significant COVID disease. So we were forced to stop them, some of them from working, and we were forced to send some of them out to work in a safer place. So those also added more pressure on the other resident and added more pressure to those residents who want to learn and keep their exposure, but unable to work because of the safety of the environment we were working on. Next. And probably, because of the significant loss of loved one, the significant loss of friend or colleague, the pressure that you're facing, the social isolation, inability to move, some of our residents and also the trainers, the consultant, the attending, they develop some post-traumatic stress disorder, and they start to be isolated, I'll say burnout, and they start coming like more lazy. And I have many of my residents calling saying they want to change their program to a different program, and this will be the last year. And I have also the first group of people that accepted to the residency training program. Some of them called and they said, we don't want to continue as an ER physician, we'll stop and will not start with you next year, which was the beginning of the year, around October. So it was very depressing time actually for the resident and the interns at that time, seeing the mortality, the difficulty, the stress. Next. If I probably mentioned that before, but we lost so many colleagues. I remember like one of our senior specialists in Jeddah, he died at the beginning of Corona. This guy, the one you're seeing his photo, is the one who died in China, the youngest physician, I think, that died from Corona in China. And we lost so many. We lost one young physician also here in Saudi Arabia, one emergency specialist. And so many of my colleagues that I know about admitted to ICU or were admitted at least to general ward because of the COVID-19. So, and this added more to the pressure and added more to the loss we have during COVID-19. Next. Not all that happened in COVID-19 was bad. So I don't want to show like it's everything in COVID-19 is bad. There is some good thing happening in COVID-19. One of the important thing was the resident confidence and their ability to manage the busy shift and the stress. So I noticed the resident, and especially in the second year, we have 4-year training program. So especially the resident in second year, we saw a lot of growing in their confidence because they dealt with a huge pressure and they were able to survive. They learned a lot. They gained a lot of new knowledge. So seeing that or following that, the resident or the trainee, they were getting more confident that they can survive this and also they can learn from this. Next. Though I was talking just now about the resident confidence, though we gain a lot of knowledge about COVID-19, and if you discuss with the trainee of that time or that era about COVID-19, you discover they know a lot of evidence, a lot of knowledge. They know how to manage the detail, but it's affected the other section in emergency and emergency training knowledge. So if you ask them about the disease that were common at my period, like MI, they probably don't know a lot because for the last 1 or 2 years they were seeing only COVID patients continuously, and they missed those patients that are previously were more common or they were more exposed to. Next. So to make the most benefit of COVID-19, we need to change our training or our way of thinking about training on the training program. So what we changed actually, and I will divide those to mini sections so to make it a little bit easier. Next, please. So one of the things that we did a focus training, and by focus training I mean on a specific task or specific function. As you all know probably, and you're working with a resident for some time now, resident of the first year, they don't know how to do intubation probably, unless they were working in a busy hospital and they were able to do this as an intern. But otherwise, most of the residents in the first and the second year cannot do intubation independently. So what we did actually, we created a simulation training task. And we start giving a focused training on intubation only because that's the most common treatment that were provided to COVID-19 patients. So we're giving an intubation. Yes, please. Next slide. So the resident, especially the junior years or the first 2 years of the program, they were doing a lot of intubation tasks, and we're sending them to different places to do and train on intubation. So they were getting focused training only on intubation. So when we get busy or get stuck with so many number of patients, the R1 and R2 can provide or at least start the intubation process before the attending were coming. So this also one of the things that we did, and it helped us really well at the beginning of COVID-19. Because with time, we start to have more senior and the training and the resident gain more confidence. So it didn't help us a lot at the end, but at the beginning, it was very, very helpful, giving the junior the confidence they need to do the intubation. Next. So one of the focus training we were doing is protocol, and probably most of you guys have some like similar protocol. The Ministry of Health here in Saudi Arabia, they announced so many protocol about Corona-19 and COVID-19, and the residents were unable to catch up with the new guideline and new update. So we're giving them a daily session, a weekly session sometimes on the update on the guideline. And one of our colleague in the training program, we're doing this session weekly, daily, as needed for all the residents. And the session was provided to everybody. And then if any update came out, there is a shared group that they can share the information and make sure everybody is focused on this new update or new guideline. Next. Not only intubation, as you're probably aware, also BiPAP and CPAP, high flow nasal cannula, other equipment we train our resident on, and I will talk about this later. But you'll probably notice that the RT also was difficult to find during the COVID-19 era. So we were forced to train the resident on using ventilator, using BiPAP, using CPAP by themselves, setting up the BiPAP or CPAP or the ventilator itself. Next. So the second part of what we did in the training program, we created just-in-time training. A lot. There is actually around 15 just-in-time training. So just-in-time training means that before you start your duty or before you start your work, this is a common term used in disaster. So we created so many courses related to the response to Corona to all residents. So when he get in the shift, he will get a new training on something new, like the example I will set next. The one of the most common thing that we train the resident on is how to use ventilators. So in the era pre-COVID-19, the respiratory therapist was responsible on the ventilator setting. I'm not sure if that applies for everybody here who's attending, but for us, it's been like, for me personally, it's been like 7 years since I touched a ventilator. So I was trained to deal with ventilator. I was doing a ventilator for whole of my life, but like starting from 2016, 17 probably, I stopped using the ventilator because of the availability of RT. But with growing pressure on the need of RT, and the COVID-19 infected most of them actually because they were close to the patient doing suctioning or physiotherapy. So we forced to teach the resident how to deal with the ventilator. Setting up the ventilator or BiPAP was one of the important just-in-time training we did at the beginning of COVID-19. Next. Disaster triage. So talking about, because I'm disaster background, so probably I'll try to put disaster in every slide I will talk about, but just bear with me for this one. So disaster triage, because the disaster training is only for the senior and in our training program. So we were forced to give some just-in-time training to our junior resident how to do a disaster triage. And the reason why we started thinking about the disaster triage, because some of the people in the dark time of COVID-19, they were coming in unrest. And most of our staff, including the resident, they don't accept if somebody came in arrest that they don't need to do CPR for. So if he's in arrest, they will ignore everybody else and they'll start doing CPR. So we train them on disaster triage because we want them to know that plaque is not resetable, especially in a disaster. And Corona was a disaster at that time, specifically in the period of high pressure at that time of the year. Next. So basic triage course, and that's not for emergency resident, but we did it for some other resident. I don't want anybody to think that our emergency, they don't know how to do triage. So I will talk about it later in changing or modifying the resident rotation. But we did train the off rotation staff on how to do a regular triage or CTAS triage for their resident and specialist specifically. We'll talk about it later, inshallah. So our residents also were making a rotation in ICU. So we trained them. We created a course for them on ICU fundamental course. And this was actually, it's a regular course for ICU staff and resident who's rotating in ICU, but it's a 5 days course. We shrunk this course to a 1 day course, actually to 3-hour course. And the resident can get the basic how to deal with ICU patient. And it was done at the same day you're starting your rotation with. So if you're starting your rotation in ICU today, you will get the 3-hour fundamental course, and then you jumped in and start working immediately because of the time limitation, as you all know. Creative tool. So next, please. So you probably saw this during the COVID-19 period. We actually created one of those to protect our residents. The number of residents were infected at the beginning of Corona. It's like hell. I don't remember any of my residents didn't get COVID-19 at the beginning of Corona. Like most of my residents were infected. And the reason why we don't have a negative pressure room, and probably most of you, they don't. Nobody expected to see this huge number of airborne, I would say, airborne disease and ED. But they came very fast, and the number of cases was very huge. So probably most of the residents catch up doing an intubation or giving a ventilation for some patient. They catch up with, or they catch a Corona virus at that time. So we created one of those while we're doing the intubation, and we even innovated even more. We created some extra space and ability to move the hand up and down. Previous. Yeah. ability to move the hand up and down. We change a lot in this box. We created like around 4 or 5. So after that, I don't think there is any evidence showing that this box really work. But for us, we notice a reduced number of infection, probably because of the herd immunity, but we're not sure. At least when we start using this one, the number of cases or the infection within residency program went a little bit down the regular range. Next, please. So if we don't have a box, we can use a bag or plastic cover. So we cover the whole patient with a plastic, and then we try to do the intubation under the plastic. This is another way also shared. You'll probably see it in many of the article that is online. So we did that also early to reduce the number of infected residents within during their shift. Next. This one of the idea that I liked. We brought actually one of the 3D printer available online, and the reason why because while the number of cases growing up, the number of supply were going down. So we used the 3D printer to print a face mask to our resident and to our staff, and this actually were used significantly at like the period of pressure. Then we were able to provide more face mask. Buying or purchasing a regular face mask from everywhere around the world when the pressure started going down, and the number of stock after that became very good. So we didn't need it, but we used it for like a 3-month period, and it was one of the best idea. One of our residents came with this idea, and we used it for a 3-month. The hospital actually, for the first time probably in the history of our nation, the hospital paid for this machine actually to get it done, to get the face mask. And we were printing only because if you know how this operates, it will print only like 10, 15 per day. You cannot print a lot, but the staff were using it for the whole day and then throw it at the end of the day. Next. So what happened in the training itself? How we modify the training on the COVID-19? Go next, please. First of all, this session, and like many other sessions, the conference or the academic activity online, it's become the gold standard now. Every hospital, every training center, they have an online academic activity. We started earlier than probably Zoom. Zoom was not available at that time when we started. It was available, but it wasn't that commonly used. So we used some Google Meet, Line, other programs that were available online. And then we moved on to Zoom when we start doing when we get the opportunity to get Zoom. Now we're using Webex, and we're mixing between online and physical activity every week. So academic activity changed significantly after Corona. And you're probably I hear a lot of people saying that I hate the online activity because we lost the interaction and the communication that what happened before in the physical activity. But it was a good solution at the beginning of COVID-19. Next. So I bought this cup intentionally because I want to talk about repurposing, and I don't want to think that anybody to think that I repurpose my resident. We did repurpose actually the resident in the training program. So our resident were trained very well in critical situation. They know how to deal with sick patient, intubation. They know how to deal with hypotensive patient who need resuscitation. So, but the two places were busy were the ED, and we have a very good, huge training program. And the other place was the ICU. They don't have any actually. Until recently, the ICU in our nation was like 2, 3, 4 residents probably the whole year. So they were not having enough residents. So what we did actually, we were sending some of our residents to do 6-month, 8-month rotation in ICU, and instead of using our resident in like low critical situation or low critical area, we were taking GS resident, urology, orthopedic, to work in the acute care in the ED. So the the ED resident will work in critical care in ED and in the ICU, while the GS resident who don't have any cases at the time of Corona, because most of the cases flow were stopped except for coronavirus. So the resident of GS, urology, orthopedic, all the surgical specialty, they were having less patients, so they were working in the ED. And those people, we created the triage course for. So they were training on triage, and they were working in triage instead of our resident and our specialist. Next, please. So Saudi Commission now have a program for supporting psychiatric illnesses for the training program resident. But before that, we created a team actually within Riyadh city. We're covering all the post-traumatic stress disorder and all the residents who in burnout, who need psychiatric support. We have two team, male and female. The male team was helping the female resident, the male resident, and the female team was helping the female resident. And this actually was started early on before the Saudi Commission starting their support program. And now we have a fully functional support program for the Saudi Commission. It's a phone call away. You can call anytime, and they will give you the support that you need. Tracking, and I don't think it's fancy as it's appearing in the image. It was actually our residents were getting infected like daily. We have like every day we have one resident with positive COVID-19. So it was difficult for the infection control within the hospital to follow the resident because they were busy following the other staff, the consultant and the other. So we created a tracking list. And at that time, one of my colleagues, they created like an Excel sheet. They were tracking the resident and they were calling the resident the first, third, and seventh day, making sure they are okay and they are not having any stress and they don't need any help. So we created a tracking list and we were clearing the resident ourselves to get back to work, arranging their swab, doing their checking up, making sure they are okay, they are not complicated, they are not dead. So a lot of things were happening with tracking, and it was a great idea of one of our colleagues. Next. So after we talk about that, and I'm sure if we talk here, everybody here will have something that they did in the training program after COVID-19. But what actually we need to think about after COVID-19? Next. So I don't think COVID-19 is something bad, but it gave us a chance to test our capability. And when we tested our capability, like I said before, I thought Riyadh will never be touched with any stress. But when we saw what happened in COVID-19, we learned that we need to develop whatever we think that we reach to a good level or a high level, we still need to work harder to reach to the next one. And that one of the important lessons learned from COVID-19. It is the future is open, and we need to grow up to at least reach to the degree that we can. The next hit, when it comes, will be at least half ready. Not ready, but half ready. Next. طبعا انا الكلمه هذه احب اقولها، الله لا يخلق شرا محضا. There is nothing called the pure evil. So coronavirus came and everybody thought, okay, this is the end of the world. But now, after we finished, and even if you remember after COVID-19, they were saying there is a new normal. Everybody was upset about the word new normal. They thought that we will walk all the time with masks on our faces, we're not able to talk to each other. And now look what happened. For us at least, the disaster training program became very strong. The disaster response became unified. The resident became stronger. Everybody now thinking about prevent the next catastrophe or incident. So the COVID-19 was really beneficial in that point. COVID-19 also gave us a chance to be more resilient. So and in disaster world, resilient mean surviving. So if you want to survive the next hit, create a resilient system that can survive the first hit and continue surviving the whole year and grows up to be a stronger system. Next. So I probably share some of our lesson that we or our modification to the training program, but I don't think like in disaster, I don't think that one size fits all. Probably if you're applying this to your hospital or your training program, I think you need to modify and mix and match between the changes that you can do that will help you develop. But if I shared my experience and you shared your experience and everybody shared their experience, somebody will get benefit of those and try to grow and survive the next. I would say I don't want to say coronavirus, but the next hit that will come to us. And for sure, if we continue doing this, we'll be stronger with time. Thank you.
Thank you very much indeed, Dr. Omar Osman. Very insightful talk. Yes, probably we are in the field of emergency and disaster medicine. We have a say. We always say we don't leave a disaster or an emergency goes a waste. yes, you took us through an interesting journey, and probably the theme of this conference is around navigating crisis with hope. And whether it's COVID-19 or armed conflict or war or even floods or even Corona X, دي اللي ما عايز تقولها دكتور عمر. So we need to learn from all the experience. Probably I will give the chance to Professor Sahel also to give a quick comment. As we're speaking, also Dr. Riabing is joining us from Florida, Miami, and we don't want to keep her waiting along. We already
Okay.
behind the schedule, and they already have an emergency going there in Florida. So the floor is yours, Professor Saab, to comment
Uh,
on the session.
yeah. Thank you very much. I would like to thank Dr. Omar Osman at various levels. The first level, thank you very much for participating. Thank you.
You're
And
welcome.
then thank you very much for sharing with us a wonderful experience. In fact, I was in Saudi Arabia and I was working in Al Marif University, and I watched what was happening, all the success stories. I'd witnessed them firsthand. So thank you very much for sharing your experience and this wonderful presentation. And also, thank you very much for those who attended your talk when they attend my talk, which is also called Post-COVID Technology Acceptance and Adoption. So you already spoke about a few things that I'm going to talk about. The same concept. It is not all bad. We learned a lot. I'm going to say things which are very similar. The good things we learned, how we changed our education, actually how people changed, not just us as educators, the families, and everybody, as far as education is concerned. So thank you very much again, and I would like to thank you for the last time, and Hisham, the floor is yours.
Thank you,
Thank you
As
very
Professor.
we
much,
say in
Professor.
emergency, out and over. What do you say? Out and over, something like that. What do you say in
Yeah, over.
emergency? Over.
This is our emergency. Over. So thank
You
you
need to
once
join
again.
us in disaster, yeah, the Prof.
Yeah, absolutely. Thank you very much, ladies and gentlemen. There is a lot of heating comments and probably questions in the chat. But yes, we will have a table free to further discuss and throw some of the questions around this session. We'll be happy to take it one by one. But now, please, I would like to thank you once again and ask you to join the next session where we will have Professor Sahel, Dr. Yabin Gao from USA, Florida, talking about some interesting topic related to quality online education, the technology adoption and adaptation after COVID-19. So welcome and thank you once again. Assalamu alaikum.
Alaikum salam.